All right, students, we are just going to finish up these didactic videos talking about cardiogenic shock. This is a PowerPoint that I did a couple years ago, overviewing all types of shock. And I'm providing you with the entire PowerPoint, not because I expect you to know all the information, but because you might find it helpful to reference in the next few days. You did cover neurogenic shock, aspects of it last semester, and so, and I believe you're going to cover septic shock in 2 weeks. So this is just giving you the entire PowerPoint so that you can review everything. So this is a great little video. It does review cardiogenic shock. I would highly recommend you watch it. You can either watch the embedded video here or find it on YouTube. So shock is basically any condition in which we're have hypoxia not only to our peripheral tissues, but also to the organs, and it's happening because of some kind of impairment or alteration in whether it's the brain that causes certain mechanisms to be affected, or the heart itself, etc. So if not treated, this is basically our last step before the patient codes and dies, multi-system organ failure. And if we don't catch it fast, then we can also end up, remember that with prolonged hypoxia, that we have necrosis of tissue. So this is not a good thing at all. So if you want to get super into the cellular thing, what's happening, you can definitely get into this. I would highly recommend this video, though. It's going to explain it very well. So our clinical manifestations of all kinds of shock really are going to be dependent on our type of shock, but our signs and symptoms are going to be very different. Our clinical manifestations, albeit the end result is the same, like we were saying, like nowhere is getting perfused. Like when we were talking about hypoxia and hypoxemia a couple weeks ago, we talked about just like the peripheral tissues not getting perfused, but in this, nothing is getting perfused. There's no shunting of blood to the major organs. There's no compensatory mechanisms. I mean, initially there are, but if we don't stop it and reverse it, then this is going to be widespread tissue necrosis. So subjective information, so this means that things that are patient reported, patient can report just, I'm not feeling good, I'm tired, I'm cold, I'm too hot, I'm very nauseous, I'm dizzy, I'm confused, that sense of impending doom, thirsty, shortness of breath. All of these are symptoms that are associated with the stimulation of the parasympathetic nervous system and a feeling of fight or flight response. And so initially we can compensate with a regular blood pressure, but our objective information that we're in a late sign of shock is going to be extreme hypotension. So we're talking about a systolic blood pressure below 60. Initially, our cardiac output and urinary output are going to be our first signs of shock. That's objective data, so we can look at and keep an eye on our urinary output, because remember, that's going to be our biggest indicator of cardiac output, unless you have a catheter in them for hemodynamic monitoring. You're going to keep an eye on your urinary output. And then, of course, we will start going into respiratory alkalosis and increasing our respiratory rate in an attempt to blow off CO2, and then becoming, having alterations in sensorium, so sensations, decreased, or a mixture of our oxygen saturations there. So again, very subjective information. Like this could be caused by a whole number of things, but our objective information, we're really looking at go back to thinking about perfusion. What is our biggest players in perfusion? That's our cardiopulmonary system. So we're going to see alterations in our cardiopulmonary system first. And these are the changes that you're going to see: a decrease in cardiac output and heading into respiratory alkalosis with an increased respiratory rate. So let's go down here. So like we said, our blood pressure tanks, our cardiac output tanks, heart rate might go up in an attempt to compensate, as well as our respiratory rate. So some stuff to look at, the perfusion concepts. Here's the 5 different types of shock that are currently recognized. We have hypovolemic shock, which you can guess what that occurs from. Neurogenic, that's what I was talking about with when we have alterations in the CNS. Cardiogenic is the one that we're going to focus on. Septic shock you're going to talk about, and anaphylactic shock, I believe you're going to talk about those 2 types of shock pretty shortly here. So let's go into this is hypovolemic. No, this is general. Sorry, just double checking. So generally, our first thing to do is we need to figure out what's going on. Well, actually, we may not be able to do this first. First, we might have to do supportive measures. But as we progress with our supportive measures, we're also thinking to ourselves, what are we going to do? What caused this? So we can start reversing it. So depending on what's happening, we're going to have to support the cardiopulmonary system. And we support the cardiopulmonary system with medications and oxygen. And we have specific treatments for each type of shock. And we're just trying to remember, if we maintain adequate blood pressure, we help maintain adequate cardiac output, and then we can maintain perfusion. So go down to slide 27 from here. So I posted the whole PowerPoint for you guys. So this is what happens in cardiac shock. We have a decrease in cardiac output. All these compensatory mechanisms start to get affected, and we have compensatory mechanisms happening. We end up seeing a decrease an initial increase in preload stroke volume and heart rate all increase initially, which increases our myocardial oxygen requirements. Then our cardiac output and ejection fraction are impacted, and this affects our blood pressure, which then affects our tissue perfusion, which impairs cellular metabolism and leads to ischemia if we have decreased tissue perfusion, which again, the ischemia affects cellular metabolism, and we get myocardial dysfunction, which goes back to decreased cardiac output and ejection fraction, which further decreases the blood pressure, which further perpetuates our problem of tissue perfusion. So it's this vicious cycle here. So we need to intervene wherever we can along this thing here. So it's about recognizing our patients who are at risk for shock. So who's at risk? So just age, because of the tired muscle, and usually by the time you reach old age, you've probably been diagnosed with some problems and are not terribly healthy. And then all of our cardiac risk factors, of course, myocardial infarction, if they have one, especially in their older age. We talked about the cardiac cripple. So if they've had a massive myocardial infarction, this can happen, especially in progressed heart failure. This can happen. This can happen in individuals with coronary artery disease. Most likely they throw a clot or have plaque rupture, and we get a myocardial infarction, and also individuals with diabetes. So if you think about anybody who has heart conditions, they are at risk for cardiogenic shock. And then diabetes affects perfusion, as we know, through arteriosclerosis. So what happens? Well, neurologically, we'll have our decreased mentation because we're not getting oxygen to the brain. Respiratorily wise, start having shortness of breath and increased respiratory rate, because we're trying to up the blow off CO2. Then we'll have both systemic and pulmonary edema, because remember, we get the systemic edema when the right side of the heart stops working as well, and then we get the left side pulmonary edema when the left side isn't working. So neither parts of the heart are working, so we start to swell up and get pulmonary edema as evidenced by crackles in the lungs. Our skin starts getting a dusky color as blood is shunted. I was going to say shunted to the major organs, but it's really not, because there's just no circulating blood volume because there's a problem with the pump. And then cardiac wise, then our blood pressure plummets because we have our heart is just not pumping. And then of course we'll see oliguria, which no cardiac output. If you don't have blood flow and blood pressure to perfuse the kidneys, then of course we're not going to have urine output. And then if you don't have blood going to the intestines, then of course we're not going to be able to move stool, and digestion can't take place in normal fashion. So management of this are all focused around supporting the heart. So we vasodilators to help to help gosh guys, I'm sorry. It's a vasodilator, smooth muscle relaxation. There we go. Vasopressors to help increase the contractility of the heart and force of contraction. So you get both dopamine and dobutamine can be involved in this. And morphine to help increase coronary artery perfusion. We give fluid volume. These people need to be intubated because they can't respiratorily support themselves. May put in an intra-aortic balloon pump, which if you remember, that was to help reduce systemic vascular resistance, and or a VAD. So that's basically an external heart. Helps if we can get early revascularization. So this was caused by an MI to do PCI or bypass surgery, but the mortality rate still remains great at 70%. So because this can happen and progress very rapidly, so that's why it's important to address early. What I want you to remember here is, again, our focus is on drugs, and we're going to focus on the vasodilator. So basically, it has two functions. As a smooth muscle relaxer, it's going to decrease systemic vascular resistance, which is what we need right now to make it easier on the heart to pump. And then it's also going to reduce afterload, again, to make it easier for the compromised left ventricle to get blood out to the tissues. So how do we know if it's working? All these are in my notes, so take a good look at them. The patient's warm and pink. So it's not going to have anything to do with oxygen levels or anything else. It's just going to have to do with, we're going to look for that warm pink skin. Our primary nursing interventions, along with the administration of drugs and support with ventilator and IABP, is going to be keeping that head of the bed or elevated to assist in the breathing. We need to make sure that we're assessing those lung sounds, because remember we said that if the left ventricle is not functioning, then we're going to get pulmonary edema. So we may have to administer Lasix. For pulmonary edema. We need to make sure that our other primary intervention is going to be frequently assessing the lung sounds, again, because we're looking at the for pulmonary edema and congestion. They usually have advanced hemodynamic monitoring, so Swan scans, catheter in, and we will give drugs off of this. So if our pulmonary artery wedge pressure is high, so we've got a lot of pressure going into the pulmonary artery, then this is it's probably due to fluid buildup, but we need to give Lasix to help with the fluid buildup, but also to help reduce preload. And then if our SVR, or systemic vascular resistance, is high, we need to titrate up on our nitroprusside to decrease systemic vascular resistance and decrease afterload. So remember that especially those things about nitroprusside. Okay, those are the biggest things I want you to remember about it. That's all on cardiogenic shock. So just a quick overview and some key points. If you do catch it and you get to work with this kind of patient, these are the kind of supportive nursing and collaborative interventions you can expect. But do remember the drug, okay? Nitroprusside.